Yes, sounds good. Arrival. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2. 1, 2, 1, 2.
Morning.
Oh, yes, yes, yes. 1, 2, 1, 2. 1, 2, 1, 2. 1, 1. 1, 2, 1, 2. I break it. 1, 2, 1, 2. 1, 2, 1, 2. That's good. Huh? Get it. Hello? 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 Shop. Okay. So what do you cut? This one. This mic level at the moment. Yeah? Or maybe cut it. Mute it. Cox, mute the music. Yeah. And then, before we test the other two mics that would be roaming mics. Okay, you're happy? Okay. Right. And this one. This should be channel 2 and 3. Yeah. 1. Okay. Yeah. Yes, sir. Unless you want to test for yourself and be all selfish. Yes. Okay. Yes. Yeah. That's both mics. For now. Yeah. Okay.
On HIV, and we spoke to Mr. Dango and Bridget Prince that were working there. We worked with Mr. Mandela. They gave us money together with the British government. It used to be called DFID. They gave us money, and we went out and we collected a sample of 10,000 people across the country. And it was very important at that particular time.
The Nelson Mandela Children's Fund and later the Nelson Mandela Foundation obtained funding from, among others, the German Corporation for International Cooperation, which was known as GTZ at that time and later became GIZ. And they requested the HSRC, together with other research bodies, in particular the South African Medical Research Council and CADRA, the Center for AIDS Development and Research, to undertake the first study in 2002, which looked at HIV prevalence, HIV risk behavior, and the impact of mass media communication campaigns.
Very early on in the AIDS pandemic, we were using data from pregnant women to give us some idea of the overall pandemic. And it became clear to us that actually what we were looking at is really good data. That even though it was a study predominantly of pregnant women, we had a pretty good idea about what was going on in the general epidemic. But it wasn't until the Nelson Mandela Foundation and the HSRC came together to do the first of those Nelson Mandela surveys Oh, I think that was like close to 20 years ago or so. But what that did was that at a time when our country had a high level of denial, or more appropriately, denial at high levels, that this survey began to make HIV real. And it was acknowledging that the problem exists, and it gave us some quantification about the nature of the problem. And I have always felt that the Nelson Mandela First Surveys was a turning point in the way in which the public understood this pandemic and the way in which they grappled with the evidence.
Every time I talk about it, I get very emotional. Because, the point is, people thought we would never pull this off. All that cynicism, how can you get into households? Just think about, and how the survey became more and more sophisticated in the way in which it gathered, information and stuff.
Among those who did not believe that HIV caused AIDS, the HIV prevalence was higher than among those who believed it. Many participants did not believe that the government was committed to addressing HIV and AIDS.
The data from the survey indeed enabled the country to develop evidence-based national strategic plans, and the surveys have been a cornerstone for evaluating the impact of the various programs. And this has ranged from, for example, the provision and coverage of antiretroviral treatment, and also the development of behavioral change communication campaigns on various issues ranging from, for example, condom use, male circumcision, stigma, and so forth.
If we had started treatment much earlier, the amount of infections that we would have prevented would have really cut down what we now have to do. We're still paying, and we're going to pay in future if our health system collapses.
Significant controversy followed the launch of the findings, with HSRC researchers being attacked by AIDS dissidents and asked by a cabinet minister to apologize, but the researchers were steadfast, speaking truth to power and urging South Africa to follow the science during this difficult time. The 2002 report was widely disseminated and covered by the media. In November 2007, Professor Likeness Simbahi presented the HSRC model of HIV surveillance to ministers in charge of HIV and AIDS during the SHEDAC Leadership Conference in Victoria Falls, Zimbabwe. The HSRC model was adopted as the gold standard for national HIV surveillance in SHEDAC countries. Since 2002, the South African HIV Behavioral, Zero Status and Media, Sabbsm, surveys have become a major source of information for measuring progress in the implementation of South Africa's National Strategic Plan to curb HIV, sexually transmitted infections and tuberculosis.
Now, for us to do that kind of work, we needed highly skilled people, people that really understand how to undertake an epidemiological study in many, many parts of the country.
I started working in HIV/AIDS research within HSRC around 2003. That is at the time when the HIV survey, the first ever to be done, had just been launched and were completed in data collection. So we're analyzing data at the time.
I started in 2002 at the very first Sabbsm. Our job was to knock on the doors, introduce the study to the people, and then get a household listing. So somebody that would basically get a census of the house, to see who actually lived in the household, get their ages, race, sex, and a few other demographic information. We then were paired with a GIS person from a different company who would then take the GPS coordinates of the located house. And at that point, we would then send this information up to the Pretoria office, and they would then do a selection to see who to actually interview in the house.
When I started, I was part of the team that did the focus groups to develop the questionnaire. Then I also conducted field work during the first survey. I went to houses to get permission to send another team to actually do the surveys. So I traveled throughout the country, knocking on doors, listing people who live in the house, and asking whether they would like to participate in the survey.
In the Sabbsm survey, I am one of the core principal investigators, and my role is leading and overseeing all the elements that are related to biomarkers. This means thinking about the assays and the algorithms that we should use to test and verify the HIV status of the people so that we can estimate accurately the prevalence of HIV in the country. It means thinking about the methodologies around testing for exposure to antiretrovirals, also looking at methodologies for incidence estimation, and also looking at HIV drug resistance. I do this work in collaboration with our partners who are experts in these areas and who also run the laboratories where we test our samples. My work also involves planning around how we collect the samples to test for these biomarkers. The collection of samples is very important, from collection to how we store them and how we manage them up until they get to the laboratory and then the testing. I also participate in the analysis of the data with a special focus on my area of the biomarkers, understanding and making sure that we have run our analysis robustly and that we also incorporate emerging trends and also advances in science. And this has been very critical, specifically in the areas of drug resistance, which have become very important as the HIV epidemic matures and as more and more people are on treatment. We know that drug resistance is part of use of any medication. And this has been one of the innovations within the Sabbsm survey series, where we are actually assessing how we're doing in terms of resistance to the virus.
In 2001, at the height of HIV and AIDS denialism in South Africa, there was little scientific evidence on HIV prevalence and behavior in the country. Before 2001, the Human Sciences Research Council had undertaken some research on HIV and AIDS, but the impact was limited as the disease was still viewed as a scourge that only affected white gay men and poor black people. The Human Sciences Research Council experts feared that the epidemic was about to cause devastation.
In 2001, one of the first things that I did was really to talk to Mr. Mandela, talk to them about, we really need to do a study, on HIV. And we spoke to Mr. Dango and Bridget Prince that were working there. We worked with Mr. Mandela. They gave us money together with the British government.
We plan to start at 10:05, but while waiting, please have a look at the photo gallery on your left there, and then you can also scan through the Mentimeter. There's a paper on your table with a code. Then you can just answer 3 questions on that web page. So please just have a look at some of the photos that we have prepared for you. Thanks.
sound is inside, yes. Yeah.
and we do that. We do acknowledge the fund. Is it a pull up like this?
Is it the same as? Is this the same size as this one? So then let's come.
So let's put it here.
colleagues, morning. We should be starting in the next 5 minutes or so. We're just asking colleagues from outside to come and join us. While waiting for that, we ask that you introduce yourself to the person that's sitting next to you, just to get to know the person, because you're going to be spending the whole day with them and have to interact with them. Secondly, those of you that have not had a chance to go to our gallery at the back, please do so. Also, scan the code and respond to the questions that are on the web page. We would like to hear from you. We are going to display your responses, so it will be great that you are able to do that. Also, to our online colleagues, we hope that you are able to see the program, and you've also were taken through the photo gallery as well. So please bear with us and use the opportunity to introduce yourself to your neighbor if you have not had, you have already completed the questions. Otherwise, this is your last opportunity before the program starts for you to also review the photo gallery that is on display at the back.
Spray bottle, sprayed in the... Only smart people know these practical life hacks. 1. Install a bottle cap under the soap. The soap can not only be waterproof, the use is also very convenient. 2. Spoon over hot water once, then brush a layer of oil in the spoon. Then put the egg. You can make a beautiful punch stick. 3. Thread the hairpin into one end of the bracelet, then wrap... without going back. 5. Remove the lid of the wet paper towel box, and then cut an oval hole in the side of the empty bottle, and then paste the lid on if an organizer. 6. The bottle cap with fire, and then cut off the bottom half of the bottle, the wire, and the bottle mount, set of sockets, and then the wire and the bottle cap. Tighten the lid, and then set into a rubber.
Hey Laura, it's me. Sorry, but I had to ring your doorbell so late. But there's something bothering me. I really am sorry, but it just couldn't wait. Is there someone else instead of me? Go ahead and lie to me and I will believe. You're not in love with him, and this fool can see that the rivers of your love flow uphill to me. Hey Laura, it's me. Sorry, but I had to ring your doorbell so late. But there's something bothering me. I really am sorry, but it just couldn't wait. With a healthy dose of make-believe, won't you lie to me and make me believe that you're in love? all night long. I just couldn't wait. With a healthy dose of make-believe, go ahead and lie to me and make me believe that you're in love with me, and oh, this fool can
Is it fine for me? This mic. Hey, I'm too short. I have disappeared. Okay. Okay. Thank you. I hope those that are outside are coming in. Now we are starting the program of the day, the agenda of the day. Anyone outside, may you please come inside so that we start. Let me take this opportunity to acknowledge all colleagues present from the province. But before I do that, I would want us to bow our heads in a silent prayer for a few minutes. May we bow our heads. Thank you, Lord, in the name of Jesus. Amen. My name is Margaret Mokotu. I am the acting head of secretariat for the Northwest Provincial Council on AIDS. The purpose of my being here is to welcome you all into this very important session of brought to us as a province by the Human Science Research Council, HSRC, in which we are going to once again, after 5 years, view how we are performing as a province in terms of the incidence, HIV incidence, prevalence, and the behavior that is driving the epidemic in the Northwest Province. So we are welcomed into this very important session, and we are looking forward for your very fruitful participation so that we can deal with the findings and see how we can, as a province, move forward in terms of us reaching the 2030 vision. Remember the time where we are as a country and as a province. We are at a time where we have our last NSP, National Strategic Plan on HIV, TB, and STI, 2023 to 2028, where we just few years to the 2030, to 2030. So this is in fact the last NSP before 2030, and we cannot do everything as usual. We need to bring business unusual into the picture for us to decisively deal with the HIV epidemic. So the survey that was conducted by HSRC in this province will bring us closer to what our challenges are and exactly where are those challenges. And we as a province, we need to put our heads together and see how we are going to close all these gaps in order for us to reach the 95 by 2025 and make sure that we eliminate the scourge of HIV and TB come 2030. So you are welcomed into this very important session and into the Northwest Province and the city of Goodwill, Mafikeng. So feel at home. We don't have dogs. We have long killed them so that you can be free. So you are free to participate and engage so that we get the best out of this study. With that, I am going to call my colleagues here
who will be facilitating the program of the day. We have Dr. Letlhogonolo Makola from HSRC, who is the Senior Research Specialist. Dr. Makola, may you come forward? And Dr. Marumo Musenuri from Office of the Premier, the Director for Research and Evaluations. Dr. Musenuri, may you kindly come forward? So I am going to hand over to the two colleagues to run and co-facilitate the program of the day. I thank you.
Thank you very much, Me. Good morning, colleagues. Good morning, researchers, activists. Let me take this opportunity to thank the opportunity to co-facilitate with my boss here. And on that note, I am going to hand over to her to lead us with the program.
No, thank you so much and good morning, everyone. And again, thank you, Ms. Margaret, for setting the tone for the day in terms of what we expect. Obviously, we'll discuss more in detail as the HSRC and its partners come in front, and also the team that is sitting with you on the tables, just to discuss some of the findings and how we then also relate that to what is happening in the province. So I'm just going to observe all protocol for in the room, but also those that have joined online. We have some of our colleagues who were not able to make it here due to the distance, and also us limiting the space in terms of how many people we are able to accommodate in the province, who are also part of these discussions, and have colleagues from the HSRC that are facilitating the online session to ensure that they are also connected. So we are not going to waste a lot of time. I'm just going to ask us to go through the program just to know what we expect of the day. From there, we'll then also go through some of the activities that we asked you to engage in before we proceed to what we also had planned. So we are going to start off with the introduction. The province will do the welcome on our behalf, and then from there, we are also going to have our partner who also are going to just address us from CDC, and then the HSRC and its partners would also present the Northwest key findings of the 6th South African National HIV Prevalence Incidence and Behavior Survey, and that team will be led by Professor Kangalani Zuma, who's the overall principal investigator. We'll then ask you to engage with the findings. The reason why we said we should meet as different stakeholders that work specifically on issues around HIV is because we wanted us to talk to these findings and also relate them to what you do. So in each table, there is an HSRC lead facilitator who's going to guide some of these discussions as we engage on the topics that are also going to be handed to you to look at. After that, we also are going to ask that one representative from your table then just share the discussions that unfolded in that small table. Obviously, you don't have to repeat what is said by another table. Just mention something that has not been shared yet for us to just see how we are making sense or reflecting on what is happening and how do we move forward. And then we are going to allow the province to then reflect on the activities that occurred at the end of, towards the end of the day, and Professor Kangalani Zuma would also close the event for us. So we hope that by 2:30 we will be done with the program. And then one of the requests that we had is that instead of having lunch at 12:30 to 1 o'clock, that we have it right at the end of the program so that colleagues colleagues are then able to engage further in the small groups and network more on the results before departing to home. And then even with the tea break that we have, we also ask that it becomes a working tea break. We have our station at the back, so you just grab and come back to your table so that you also have a discussion. So we hope that we will have enriched discussions today, and hence we also made sure that we pre-seat you so that you sit with someone that does not come from an organization but that does the work that may be similar to you, so that we see how we can really ensure that we use the time that we have to really engage as much as possible. So that is what we have planned for you for the day. And before we go into the welcome address from the province, I'm just going to call Dr. Mosenogui just for us to look at some of the questions that you responded to as you were coming in, looking into the expectation. You can just join me here, looking into your expectation of the day. What is it that when you were invited, you thought we would be discussing or you expect us to share with you? And then we would also look into how you reflected on the work that has been curated at the back that was led by Dr. Sahir Parker and colleagues from SANEC that thought we would need to look at the journey that we've been through as South Africa in terms of HIV and look at where we come from and where we are as well. So I'm just asking our colleagues to display the Mentimeter responses there. And then those of you that have not had a chance to look at the pictures, of course, during tea time, before we even leave, you have a chance to look at those pictures. We also have our candles on as part of our reflection on this journey that we've really worked hard as a collective to ensure that we are here today. So if we can just have those displayed. If you had not had your chance to also type in your response, obviously as you talk to your colleagues in your table, you can also just use that opportunity to indicate if there was something unique that you would have wanted to share. Otherwise, I'm sure the views that are going to be shared are the views that are going to would have resonate with you. So we seem to have a bit of a technical glitch, so we will skip that response and we'll see during the program if we will have an opportunity to also just display some of your reflections. And then with that, I'm going to ask Dr. Mosenogui to then introduce the Office of the Premier DDG for a welcome address. Thank you.
Thank you very much, Dr. Makula, my boss. Colleagues, there is a QPR scan code on your table. Please have a look at it so that you can respond to the questions that Doc just spoke to. Secondly, the washrooms, bathrooms, is short left. When you go out of the door, you just turn left, then immediate left. Our bathrooms are there. The Wi-Fi is open, but the rule of the game today is that you don't go into WhatsApp. You don't go into Facebook. You only scan that QR code scan and then you respond to the questions. So I will be monitoring. We've got a sensor up there. It has a camera on it. When you are WhatsApp, don't be shocked when you see your screen being displayed up here. So it's quite possible that that will happen today. It's automated, so nobody will be pressing. Immediately when it sends that you are on WhatsApp, it will automatically reflect your chats on the screen. And on that note, colleagues, may I take this opportunity to welcome my other boss. I'm so rich, colleagues. I've got so many bosses. My other boss, Re Tsietsi Mawelela, the Deputy Director General from Office of the Premier, to give us a welcome address. Over to you, DDG.
No, thanks very much,
co-director of this session, Dr. Mosenugi. And also let me thank Dr. Letlogonolo, the other co-director, for giving me this opportunity to welcome you to the province of Northwest. I hope that you are bringing in good news for the province in terms of the survey that HSRC has conducted. Let me also indicate that this session happened at a very important time in the planning cycle of government. As you know that we have just come out of elections, this new administration, and we are in a process wherein we are putting together a program of action for the next 5 years for the current administration. And the issue of HIV and AIDS, it's one of the issues that will form part of that program. And more so that we are also in a process whereby we are resuscitating the Provincial Council on AIDS. I see some of the leadership from the council are here. So the knowledge and information that will come out of this session will be very, very, very important for government broadly, in a sense that it will inform us where to put, the resources, where we have the resources. But most importantly, I note that there are also a number of development partners here. And I know that funding for these programs is one of the issues that we are contending with. And I think that this will also become a seed whereby we strengthen all the partnerships that we've had, and we are able to even support as many of our, especially civil society, because they do a lot of work without resources, and they assist government in the work that we are doing. But I must also appreciate the work that is also done by the development partners that are funding the HIV/AIDS programs. So I thought I should mention these two things because whatever that is going to come out of here will inform the program of the Provincial Council on AIDS, but will also inform the work which government is going to be seized with in the next 5 years. Let me, without any waste of time, also take this opportunity to acknowledge all the people that will be participating in this program. Thank you very much. Let me acknowledge all the people that will be participating from this program. We have partners that are coming from the Provincial Council on AIDS. I will start with them there, and it's deliberate that I start there because from the province, the response is driven by the tripartite alliance, that is government, civil society, as well as business. Of course, development partners are also in the fold. So I want to acknowledge in our present the presence of our civil society. I'm not sure, I've not seen the chairperson, Mildred Marupefela. Let me acknowledge her as the co-chairperson of the Council on AIDS. And then we also have Mr. Zanele Fumba, who's the chairperson of Civil Society Forum in the Ngaka Mulema district. I'm not sure if Mr. Sifumba is here. Yeah, let's give them a round of applause, yeah? And then I also want to acknowledge the presence of the chairperson of civil society for Dr. Kenneth Kaunda, Mr. Mohau Kobedi. And then let me also acknowledge the chairperson of Civil Society Forum, Dimakatso Mulusi. We also have representatives from the various government departments. We have representatives from the Department of Health. I'm not sure who's from the Department of Health. All right. Department of Education, Department of Social Development, Correctional Services, okay. We also have representatives from SANAC, South African National AIDS Council. I'm not sure if they are here. Okay, thank you very much. We also have representatives from SALGA, responsible for our municipalities. SALGA, is SALGA here? Okay. And then we also have the Ngaka Mudire Mulema special programs, representatives from special programs from Ngaka Mudire Mulema. Okay. Yeah. Let me then now move to our development partners. Do we have reps from Oram Institute? Okay. Can we introduce? Yes, we do have. Center for Disease Control and Prevention. Okay, we do have as well PEPFAR. We do have PEPFAR. And then we also have our implementing partners as well. I will start with HIV South Africa. Thank you very much. Shout it now. Right to Care. Sisonke. Lifeline. Show me your number. TB, HIV Care, and Gay Umbrella. All right. We also have our higher education institutions, including our TVETs college. I will start with Northwest University I want to acknowledge Professor Matsipani. Okay. And then I'm not sure if there are other reps from the university. All right. We also have another rep from the university. And then let's also acknowledge the presence of our TVET colleges. Orbit, do we have somebody from Orbit? Vuselela. Yeah, those are the two that I know. If there's one that I've missed, you will, which one? Taletso, yes, Taletso as well, yes. Yeah, we do have a rep from Taletso. And then we also have research institutions, Madibeng Center for Research. Thank you very much. Yeah, I think I've covered all the credentials of partners, leadership from our Provincial Council on AIDS, particularly from the civil society, and all the districts. If I've not mentioned any institution, you will pardon me, it was not deliberate, but your presence is welcome. Oh, PCA Secretariat, yes. Yeah. Yeah, thank you very much, Ntate Pastor Moremi, yeah, for reminding me of the PCA Secretariat led by the head of the Secretariat, yeah. Yeah. And then, of course, finally, I think we also have our important guests from the HSRC. You are all welcome. Thank you very much and enjoy the session. Thank you.
Thank you so much, Ntate Mawelela. Just to note, colleagues, that as we mentioned, we are live streaming. There's also media presence, and there are pictures that are being taken, and also colleagues that are also taking videos as part of engaging with their team members or colleagues that would not join us. So please do not feel, if you are feeling uncomfortable, just let us know, but that is why these pictures are being taken. So I'm going to ask Ms. Paula Morgan, who is the CDC Deputy Country Director, to join us and address us. Thank you.
Good morning, everybody. First of all, I just wanted to observe all protocols and welcome everyone and thank you for inviting us to be here with you. And to really thank and reflect in the room for the opportunity to be able to learn more and share the latest HIV data for Northwest. I would like to congratulate the HSRC, its partners, and the government of South Africa for completing the 6th National HIV Household Survey and for an impressive legacy of leading national HIV surveys in South Africa and actually in the region and globally over the past 20 years. You should be very proud. Thank you. I know I'm very tall. You should be very proud of your accomplishments. You have set the tone for the world in this respect. And so we're very, very humbled to be part of this partnership. Sabbsm is a survey led by the South African scientists to improve the lives of all South Africans. As such, this survey demonstrates how investments in key partners and institutions has established a legacy of country-owned data, of infrastructure, and capacity to respond to current and future health threats. And you've done this over basically 20 years. So congratulations for that. As the As the U.S. Centers for Disease Control and Prevention, or as we call us here, the SACDC, we are proud to have collaborated with you guys, with HSRC, over the years on this important set of surveys. CDC has been partnering with you since 2005 to conduct Sabbsm surveys through financial and technical support. But it's truly a scientific partnership. And it's been made possible by funding from the US President's Emergency Plan for AIDS Relief, or as you all know as PEPFAR. Today's dialogue is just the beginning of a conversation with the Department of Health and other parts of Northwest government to see how we can use this new data to inform program strategies and to inform planning going forward in Northwest. As with previously rounds of the survey, the Sabbsm team made granular data available to guide programming for HIV care and treatment, to also inform prevention interventions, including key data for model HIV estimates, both at the national, the provincial, and district levels, such as Tembisa and Naomi. The findings here at the national level are encouraging and demonstrate how South Africa's HIV policies and programs have contributed to a stabilizing HIV epidemic, increasing levels of population viral load suppression, and promising trends in HIV prevalence and incidence reductions among adolescent girls and young women. We've got a long way to go, but it does look promising. We're not there yet. But the work we've done together in partnership with you guys, with our partners, with our government, show promise and show the right trends. This survey has helped us understand where we have made great progress, in which areas we now need to focus more on. And with this data, we can strengthen our programs in HIV prevention, including HIV testing, especially for young men and for youth. As we discuss the results of Sabbsm 6 and their implications for the HIV response here in your province, in your districts, let us remember the very different context we were at when the survey was first conducted 2 decades ago. Again, we've come a long way. We're not quite there yet, but we've come a long way. Let's not forget the progress we've made together. From a time when treatment was not easily accessed, and where there was more despair than hope, we now have highly effective treatment that is widely and freely available. We just need to get people to stay on it. This treatment not only preserves lives, health, and families and communities, but we now know that ART prevents onward transmission of the virus. And this is where U equals U is so key and so important. And what do I mean by U equals U? I mean undetectable equals untransmittable. A person that is on ART with an undetectable viral load has zero risk, and I repeat, zero risk of transmitting HIV to their partners. We're talking about sexual transmission. But if you, as an HIV positive individual, are on ART and are virally suppressed, you will not pass HIV to your partner. The Minister of Health earlier this year launched the U equals U campaigns nationally, and PEPFAR and CDC particularly look forward to collaboratively support dissemination of this important message in Northwest and beyond. U equals U is not only an important message to address stigma and self-stigma, but research conducted in South Africa has shown that U equals U has an incredibly positive impact on our public health priorities, leading to significant improvement on HIV testing uptake, on retention, and on ART and viral load suppression. We need to focus our efforts on who does not know their status, who is not on treatment, and who is not virally suppressed. These are the drivers of new infections. And we need to use that opportunity to teach those that are not yet on treatment about U equals U and what that message represents. For those that are on treatment and are virally suppressed, they should be loudly celebrated and supported and not stigmatized. They are the ones that will not transmit to their partners. The Sabbsm data will allow us to target our efforts towards finding those that may know their status but are not on treatment, or that they may not know that they're HIV infected, and linking those in need of treatment and prevention services. By focusing the lens on provincial and district level data, today's dialogue sets the stage for continued discussion within Northwest about how this data can inform our very targeted HIV program and strategies to best meet the needs of our communities here on the ground. Finally, I must acknowledge and thank the more than 5,900 residents of your province who contributed to the Sabbsm 6 by opening their doors and their hearts to the HSRT team and participating in the study. I would also like to thank the Northwest Province Government, the Department of Health, Department of Education, Social Development, and others, and of course our community advocates for your support, for your engagement, but above all, for our continued partnership. I very much look forward to this discussion, and thank you so very much.
Thank you so much, May Morgan. So we are moving on to the much-awaited Northwest provincial and district level key findings of the 6th South African National HIV Prevalence Incidence and Behavior Survey that are going to be presented by a team from HSRC and CDC that are led by Professor Kangalani Zuma. He will then just indicate the colleagues that would be joining him to share the findings. Please, a warm welcome to him. Thank you.
Thank you very much, Program Director, Program Directors, my two bosses at present today. Colleagues, I will piggyback, thank you so much. I will piggyback on the detailed acknowledgements that were well presented by Ntate Mawelele, and I'll just slide in and say, all protocols observed. Ladies and gentlemen, good morning to you. Colleagues, it's really a pleasure for me that we continue talking about the epidemic that has been with us for a number of years, that which it seems a number of our colleagues or our people out there think that we no longer have a problem of HIV, maybe because the focus is on other epidemics, but well, the numbers are showing that we still have a problem of HIV in our country, and also there is a lot that still needs to be done to actually get to the point that we need to get to. As my colleague Paula has indicated, that we have made great strides, but there is still a lot that needs to be done. Without further ado, colleagues, let me take you through the presentation, that which focuses on the results of the province of Northwest. The presentation will cover the background to the survey. We'll talk about how the study has been designed. We'll talk about specific results for the province, and we'll place the province in relation to where we are as a country and also where we are in the province of Limpopo, province of Northwest. You know, no, it's because I was hammered in Limpopo for not knowing how to pronounce the name of the province. So I've been practicing it here. Now, Northwest, it's much easier for me. So we'll talk about the results, the proportions of people who are on ARVs and those that are virally suppressed or those that are not virally suppressed. And we'll talk about what could possibly be the key drivers to the epidemic. Colleague, this is a study that has been implemented by HSRC together with its partners for a number of years. We implemented this study for the first time in 2002, at the time whereby living with HIV was the scariest thing and also was, in quote, synonymous to a death sentence. As my colleague O'Kane indicated, that, if you look at where we were before and where we are today, we are at a time where you can talk about living with HIV, living a normal life with HIV, living a life such that if you're on ARVs and you're virally suppressed, the chances of transmitting a virus to the next person during a sexual conduct, it's almost negligible. It's zero. We couldn't talk or even think about that during that time. So the study has grown over a number of years. Earlier on, we used to get to a household and randomly select at most 4 people in the household, invite them to participate in the study. And the study has expanded in the sense that now we invite everybody in the household to participate in the study. So we call it a take-all approach. We have increased the number of biomarkers. Depending on where we are with the epidemic, we increase the number of biomarkers so that we are able to respond and get the statistics that actually tell us where we are with the HIV epidemic. And the study, colleagues, has been a major source of information for our national strategic plan over the years. We've been doing the study over the years, and now we're implementing the 6th wave of the survey together with our partners. And since 2005, we've been working together, CDC, PEPFAR, on the study, and we're indeed grateful that they've been there with us as we're implementing the survey, and hopefully in the next survey, we'll be able to implement and funding permits, colleagues. Now, the main objectives of the study is to present the results at national level, that's the prevalent, at national level, at provincial level, as well as some selected districts. Now, previously, as we said, we used to present results at national level and provincial level, but this time around, we've got, in fact, since 2017, we have a sample of districts in the country wherein we have sufficient numbers to actually present results at the lowest level, at the district as the lowest level. So not all districts are included, and of course it would be nice to include all the districts in the country, but of course budget constraints could be a limiting factor. If more funds become available, hopefully we can be able to do that. Now, the results that we present is to give us an indication of where we are in terms of HIV prevalence at national level, provincial and districts, the exposure to antiretroviral treatment, as well as proportions of people who are infected with HIV who are virally suppressed. And also to estimate, colleagues, the incidence of HIV. Now, the incidence of HIV, we can only present those statistics at national level. The reason being to be able to have sufficient numbers of incident cases, that is the people who have seroconverted, who were HIV negative over a period of a year, who became HIV positive, you would need to have so many people seroconverting so that you are able to have sufficient numbers to present those statistics. So it is a statistics that we want to have. It's a statistics that we want to be able to present even at the lowest level. But unfortunately, we will need to have events that we would not be happy about, that is having as many people getting infected with HIV to be able to present those statistics. So we'd want the numbers, but we don't want the journey that will help us get to those numbers. So the fact that we are unable to present incidence statistics at the lowest level, in a way it's a good thing, because it means not as many people are getting infected with HIV such that we are able to provide those statistics. But at national level, we were able to present those results. So how is this study designed? As indicated, we present results at national level, and the survey is stratified by province. So we present results down to the level of a province, all the 9 provinces, and also we have 33 districts, that which we have sufficient numbers to present at that level. 27 of these districts are the PEPFAR priority districts, and 6 of these districts were the districts that were identified by National Department of Health as districts that which we need to have statistics from those. Now, in implementing this survey, the country is divided into what you call small area layers. These are small geographic communities that have about 250 to about 350 households. The whole country has about 84,000 of these. So each and every area, including the area where we are, belongs to a particular small area layer. Statistics South Africa actually has that database. As an institution, HSRC, we randomly select a number of these small area layers. Sufficient numbers of these small area layers, over 2,000 of these, are randomly selected as primary sampling unit. Within these small area layers, we then randomly select 15 visiting points. These are dwelling units that we map, identify the GPS coordinates and put dots on the map so that our data collectors go exactly to the household that has been selected. And then once the household has been identified, randomly selected, mapped, data collectors go there, then they invite everyone to participate in the study. So it's a multi-stage survey in the sense that we randomly select these small area layers. Within them, we randomly select household. Within these households, we invite everyone to participate. So we've got a cluster in each and every small area layer. We've got a cluster of these dwelling units that are invited to participate. It is a cross-sectional survey because we go to the household at that particular time once. It's a cross-sectional survey in that design, and it is stratified because we stratify by province, we stratify by geotype, we also stratify by districts. So that is why we say the design is cross-sectional, population-based also survey that uses a multi-stage stratified cluster random sample because of a cluster of households within each and every one of these small area layers. So persons of all ages that are living in South Africa were invited to participate. So it's everyone living within the borders of South Africa, irrespective of your nationality. And then data was collected from January 2022 up to April 2023. And we expected in the province, actually, we expected more than about 100,000 people to participate in this survey. Specifically in the province of Northwest, over 7,000 people were expected to participate. Now, the red dots there, colleagues, just indicate each dot. It's actually the small area layers that were randomly selected in the province of Northwest. So you can see in the districts where we had sufficient small area layers, we've got a bigger cluster, like if you go towards, for example, the Bojanala areas, you can see the large number of these dots indicating that this is one of the districts, for example, that we had sufficient numbers of small area layers such that we are able to provide statistics at that level. Now, once we get to a household, we have a questionnaire that we use, which we call a household questionnaire. With this household, we do a listing of all members of people within the household. So this is the questionnaire that also we use to collect information about the household situation. So it's a household census questionnaire that we use. Once people agree to participate, they've been identified and they agreed to participate, depending on their ages, we then implement a questionnaire that is relevant to their age. For example, young ones who are aged 0 to under 12, we administer a questionnaire among them. The parents or a guardian respond to the questionnaire on behalf of the child. And then we have another questionnaire, which is, we call it a child questionnaire, that's administered to a 12 to 14-year-old. Those ones respond to the questionnaire themselves. We also, within that questionnaire, we have some basic questions about their sexual behavior. We then have another more detailed questionnaire where we ask quite a number of questions about HIV epidemic, knowledge, attitude. That's the CAP survey of the study. So this is implemented among those that are 15 years and above. Once the questionnaire is completed, then we invite people to provide a blood specimen. Now that blood specimen is the one that we merge or we link with the questionnaire to have what you call a second generation surveillance survey. And these surveys have been tested over the years in implementing the Sabbsm survey. This design has actually been adopted as the gold standard in implementing this survey, and it is implemented by other countries in doing similar survey. Now, how do we collect specimen for testing? We do what you call a dry blood spot. Among children younger than 2 years, we do a heel prick. But among those that are older than 2 years, we do a finger prick. And then we do spotting so that we take that Guthrie card to the lab for testing of all different biomarkers that we're interested in. And just a list of the tests that we conduct. The first one is to test whether a person is living with HIV or not. And obviously, we do a confirmatory test to confirm that those that are positive are truly positive, and those that are negative are indeed truly negative. Once a person has tested HIV positive, and we can confirm, and we have confirmed that the person is HIV positive, and if that person is above 2 years and above, the blood specimen is then taken to another lab, which actually does what you call incidence testing, where we test whether a person has been recently infected. So if a person has been recently infected, it is that information that we mathematically use to calculate the incidence of HIV, so that we can say over a period of 12 months, how many people, or how out of people that were found to be HIV negative at the beginning of the year, how many of them would have seroconverted and became HIV positive at the end of the year? So that is the incidence, that's how we get it. In relation, for example, to the prevalence, which is the cumulative number of the people that are living with HIV. The further test that we do is the ARVs. So for those that test positive, we then take another specimen there, which is tested whether those people actually are taking any of the ARVs that we have. So it is that response to that test that gives us an indication whether a person is taking ARVs or not. Also, the viral load, we test whether, we get the level of the viral load so that we can be able to indicate whether a person is virally suppressed or not. I'll hasten to indicate, colleagues, that because we use a dry blood spot, we are only able to detect the levels of viral load, the lowest up to or minimum of about 800 copies of the viral load. So now, our viral suppression, when we say a person is virally suppressed in surveillance, the cutoff point is that of 1,000. So a person whose levels of viral load, the copies are less than 1,000 copies, that person is classified to be virally suppressed. Obviously, other tests that require or that are based on a full blood, for example, are able to detect even a lower level than 800. But in this case, we use a dry blood spot, so that is the limitation that we have. But that is acceptable in the surveillance studies. Now, we come now to the results as to where we are with HIV epidemic in the province of Northwest. Okay. Now, a total of just above 2,400 dwelling units were visited, and 92% of them were found to be valid. Why valid? Because the study goes to households. And when we do a random sample, some of the households or some of the dwelling units actually would be vacant, or some of them will find that it's a shop and there's no one that lives there. So those are indicated as invalid because they are not truly households as we intended in the study. So of the valid household, 83% of them agreed to complete the questionnaire. Obviously, the other percent did not want any work being done, and that is why, colleagues, I will really impress on you that when we implement these studies going forward, we do need to work together to improve the response rate, to encourage people to participate in these studies, because it is with their participation that we can get information, that we can know where we are with HIV epidemic, that we can prepare interventions to deal with HIV epidemic. So we all collectively here need to work together to encourage people to participate in these studies. Now, in this, almost 6,000 people were found to be eligible to participate in the study, and 90.6% of them were interviewed. So that is, they completed a questionnaire. Of those that completed a questionnaire, 64% provided a blood specimen. So you can see, colleagues, that once our data collectors are allowed to conduct the study, participation improves at an individual level to about almost 91%. So which means if we can improve household participation, we're in quote given for free that individual participation will improve. So that is where, again, we need to work together, because if we can't find a household, or if a household refuses to participate, it's quite a number of individuals that we lose that are potential participants to the study. Also, colleagues, women were more likely to participate compared to males. So we do need to work hard to encourage males to participate in these studies. And the attitude that sometimes we see among males of not being responsible when it comes to health issues needs to change, because HIV epidemic knows no race, it knows no gender. Now, coming to HIV prevalence, the proportions of people living with HIV in the country. 14% of people were found to have been living with HIV in the country by 2017. That's the survey that we did in 2017. In 2022, the statistics had gone down to 12.7%. Now, the reduction in HIV prevalence, we always need to interpret this in context, because there are a number of reasons why HIV prevalence would go down. One of them is that if people were more likely to be living with HIV and who knew that were living with HIV were less likely to participate, that could bring about a decline in HIV prevalence. Or else, if people that were living with HIV, if mortality was higher among people living with HIV compared to those that were not living with HIV, then that could lead to a drop or a decline in HIV prevalence. So we always need to understand what contributes to these numbers. In the same way, an increase in HIV prevalence can be as a result, or the other possibility of decline in HIV in prevalence could be that if more people are born HIV negative, that's population growth. If more people are born HIV negative and those that are positive remain positive and not transmitting the virus, obviously, because we're increasing the denominator of people that are HIV negative, then the prevalence would go down. So we need to always understand the context behind the numbers. Now, in the province of Northwest, in the province, it is, if you look in relation to other provinces, HIV prevalence fell down in 2017 from 14.8% down to 12.3%. And also, if you look at the order by province, the province of Northwest is the one that has the 5th largest HIV prevalence at 12.3. Oh, thank you so much. At 12.3%. So it comes just after the province of Eastern Cape. Now, 12.3% of people living in the province of Gauteng are HIV positive. But what does that translate to? Now, that translates to almost 500,000 people living with HIV in the province of Northwest. Almost half of people living in Eswatini, for example, if they were, half of them were HIV positive. That's what the number is saying to us. So almost 500,000 people in the province of Northwest are living with HIV. That's quite a large number. And of course, we need to again look at this number in relation to how many people are on ARVs and how many people are virally suppressed. Because it is the viral suppression that we need, or high levels of viral suppression that we need to achieve. Now, by age, if we compare 2017 and 2022, maybe let me start here. We see here that in 2017, the peak was at 36.5, and the next peak, so it's a multimodal graph, was at 36.8 also. Now, the graph here in 2022, we can see it is shifting towards the right-hand side. That's actually an indication of an aging epidemic. So that is, people are actually living longer with HIV. Because if people were dying in numbers like we had many, many years ago, you wouldn't expect that a person that was there in 2017 would still have that chance of being there 5 years later. But the graph here is showing that actually, most likely, people that were alive in 2017 are still alive in 2022. And that could only be because more people are on ARVs. So the graph is showing an aging epidemic, which is in a way is good news because people are living longer. Now, let's look among younger people, those that are younger than 25 years of age. What we would expect is that among young people, let's start, for example, 0 to 14, HIV prevalence has not changed. So which means what one would expect is that more and more children are actually born HIV negative. But here it says the numbers have actually not changed. Still 1.3 now, it was 1.5 before. And most of young ones, 0 to 14, it's actually like HIV that is related to mother-to-child transmission. So the question I would ask is, why are we not seeing even fewer babies born HIV negative in 2022 compared to 2017? So that's a concern for me because we, at this day in the epidemic, we expect to see very few children being born HIV positive. Okay. Let's look at the 15 to 19-year-olds, colleagues. If our prevention messages were there and they were listened to, one would expect that if you compare 2022 to 2017, one would expect that fewer infections actually take place in 2022 compared to 2017 because of the messages, condom use, and knowledge about HIV and all those issues. So remember, colleagues, that among young people, most of the infections there are new infections. Find that if they are born HIV negative, at this stage, that's when they start being sexually active. And if you look at these statistics, it is a concern that a 16-year-old in 2017, the prevalence was 3.2, as an example. But in 2022, the chances of that 16-year-old being infected with HIV is even higher than we were, or than what we had in 2022. Sorry, than what we had in 2017. So the prevalence of HIV is higher in 2022 than it was in 2017 among 15 to 19-year-olds. And that is a concern. Going forward, 2020 to among those that are aged 20 years to those that are aged 24 years, prevalence of HIV is not significantly different, even though it is lower in 2022 than it was in 2017, but it is not statistically significant. One would expect a picture that shows a clear drop in HIV prevalence among young people in 2022 compared to 2017, as we see a stretch among older people, that older people are living longer. So which actually, if you compare these two ends of the graph, is that those that are old are living longer with HIV, most likely because they are on ARVs. But those that are young are still getting infected with HIV, and that is something that we need to be worried about. Now, by demographics, of course, we've seen in many other studies that HIV prevalence is much higher among females compared to males, but of course, generally, it's because of our biological makeup, higher risk of HIV transmission from males to females than other way around. And also, again, we can see that overall, HIV prevalence increases by age, and most probably, the older people are more likely to be on ARVs and living longer. Now, HIV prevalence, we see that is much higher, actually slightly higher in urban areas and also followed by rural areas, and the pattern is still similar for males and females, irrespective of whether they are in urban, rural, or tribal areas. Now, by district, Bojanala district has the highest prevalence of HIV compared to the other two districts where we had sufficient data. The other two districts were around 11.9 to 13.6 in terms of the prevalence. So Bojanala district has the highest prevalence, but again, we need to look at it in relation to access to treatment, in relation to viral suppression, because a district or a province can have higher prevalence of HIV, but if it also has most people on ARVs and most people virally suppressed, well, the challenges in that province are less than a province that has the low prevalence of HIV, but very low access to treatment and very low viral suppression. Because if we have few people that are virally suppressed, the risk of transmission in that province continues. So always need to interpret this in context. Access to treatment, antiretroviral treatment. From 2017 to 2022, the numbers have improved in the province from 60.7% up to 78.9%. And you remember the prevalence of HIV, we were the 5th province, but in terms of access to treatment, we are the 3rd lowest province. So the chances of being on treatment, if you are in the Northwest province, are much lower than actually the other 6 provinces there. So we're at 78.9, followed by Western Cape and least in Gauteng. So we do need to improve the proportions of people that are on treatment, because this actually says out of almost 500,000 people that are living with the HIV, only 100,000, actually 100,000 of them are not on treatment. So out of almost 500,000, 100,000 of them are not on treatment. So it is those people that we need to identify and make sure that we put them on treatment for us to achieve the levels of viral suppression that we would want. And if you look at the graph which shows the numbers, we see that females are more likely to be on treatment compared to males. Low level 69.9. And if you remember, males were less likely to participate compared to females. So we've got a group of males out there who are living with HIV but are not on treatment, and they don't even want to participate in the studies. So we as men, we need to encourage other males to participate in these studies. The other thing that is of concern, colleagues, is that you will remember that in the graph, we did have statistics of HIV prevalence among young people, 0 to 14, 15 to 19, 20 to 24. We did have statistics of HIV prevalence. However, when it comes to antiretroviral treatment, the numbers of people that were on treatment and who were young were so low that actually we could not be able to report those statistics. So the fact that there are no numbers there is actually a concern, because those people that were HIV positive, they ought to be on treatment. We're using a test and treat policy now. But in this case, we had so many people that were HIV positive, but we did not have sufficient numbers on treatment to be able to statistically report those numbers. So these gaps are a concern. We do need to get young people to be put on treatment. And we'll see when we look at the gaps in access to treatment that young people, they continue to pose a concern. And if you remember the graph, young people, the prevalence among them, 15 to 19-year-old, is much higher in 2022 than we had in 2017, and they are not on treatment. So we should be worried about that, colleagues. Or not as many of them were on treatment to be able to report the statistics. Now, if you remember, Bojanala had the highest prevalence of HIV, but it is among the districts that had the lowest numbers of people that are on treatment. So having higher prevalence of HIV and fewer people on ARVs is a concern, colleagues, that we need to address. Because what we want as many people, at least 95% of people that are living with HIV must be on treatment. That's the target that we want to achieve. So the discrepancy is something that is a gap that we need to address. Now, viral load suppression in the province of Northwest, it is the area where we have the fewest proportions of people that are virally suppressed. Even though we show an improvement from 2017 to 2022, but we are the province that has the lowest proportions of people that are virally suppressed, together the province of Limpopo. So, this in the province of Northwest, it actually says more than 160,000 people who were living with HIV were not virally suppressed. So out of almost 500,000 people living with HIV, more than 160,000 of them were not virally suppressed. And if you look at our goal of U equals U, these colleagues that are not virally suppressed, they still pose a risk of transmitting the virus. So again, we need to identify who are these people, where are they, we put them on treatment, we make sure that they take treatment. And remember, this is the population viral load. So it includes those that are living with HIV and they don't know that they're living with HIV, those that are living with HIV, they know that they're living with HIV, but they are not on treatment. So it's the population viral load that we're talking about at this stage. And now we will come to the 95-95 in a minute or two. Again, the graph still the same. Females are more likely to be virally suppressed compared to males. And also, the numbers among young people are so small that we're unable to report. So which means you've got young people that are living with HIV, and the prevalence is increasing among them, but they're less likely to be on treatment, and therefore they're also less likely to be virally suppressed. And more often than not, among young people, we find that actually they don't even know their HIV status, and they could actually be engaging in unprotected sexual intercourse, putting them at risk of HIV, because they don't know their status, they are HIV positive, they don't know that, they are not on treatment, and they're least likely to be virally suppressed. Now, overall viral load suppression, again, Bojanala had the highest prevalence, the one that district that has the lowest proportions of people on treatment, and also then has the lowest proportions of people that are virally suppressed. Because again, colleagues, once we have less or we have fewer people on treatment, most likely it follows that people will be less likely to be virally suppressed, because we've seen, and the numbers have shown, that once people are on treatment and they take their treatment as prescribed, the levels of viral suppression, they improve a lot. Now, coming to now the 95 target, that is, one being aware or know his or her HIV status, and of those people that know their HIV status, whether they were on ART or not, and of those that know their HIV status and whether on ART or not, people that were virally suppressed. Now, how do we construct knowledge of HIV status? Is those people that reported that they were living with HIV, or is people that tested positive for ARVs? Because the assumption is that if you test positive for ARVs, you are taking medication, and you are taking that medication because you know that you are living with HIV. Because you must test first before you can be put on treatment. Or people that self-reported that they were using on ART. Remember, in a survey, people have a right to respond to or not respond to your questions. They can choose which questions they want to respond to. Some people would say, I'm not interested in testing, but when we ask them about their HIV status, they tell that I'm living with HIV, I'm on ARVs. So again, those people were included. That is why when we come to on ART, it's those people that tested positive and those people that self-reported that they were on ART. And then when it comes to viral suppression, obviously, it's those that provided the blood specimen. So just to indicate so that when we look at the numbers, we have an indication of what contributed to these numbers. Now, as a province, as you know, our target is 95, 95, 95. So as a province, almost 91% of people that were living with HIV were aware of their HIV status. So we're less than the 95 that we are targeting. And among those people that were on ART, 89% of people that were living with HIV and knew their HIV status were on ART. And those people who knew their HIV status and were on ART, 93% of them were virally suppressed. So you can see that once people are on ART, the viral suppression levels, they actually go up. And the numbers are showing that females or women are more likely to know their HIV status compared to males. And also, women are more likely to be on ART compared to males. And women are more likely to be virally suppressed compared to males. So there is a lot of work that we need to do among males to get them to know their HIV status, to get them to be put on treatment, and making sure that they take their treatment consistently so that we can achieve the numbers. And again, the numbers of awareness are higher among the older people, 25 years and above. And again, going back, the 15 to 24-year-olds, the numbers knowing their HIV status were so low to be able to report. Now, if you remember that graph, which is showing that in 2022, the prevalence is higher than we had among young people in 2017, coupled with the fact that young people, 15 to 24-year-old, most of them don't know their HIV status. That is a concern, that is an indication of the areas that we need to be attending to deal with HIV epidemic. Similarly, most of the young people are not on ARVs because there were not sufficient numbers for us to be able to report. And also then, by default, not being on ARVs, we do not have sufficient numbers for us to report on their viral load suppression. So the fact that there are no numbers, it tells us a lot of concerning statistics. So again, the older people were, the more likely they were to know their HIV status, although it's still below the target numbers in most areas, except those that are 50 years and above. Now, coming to the districts. Again, the districts, Kenneth Kaunda, the one that is the highest proportion of people that were aware of their HIV status. Ngaka Modiri Molema, as well as Boshanala, the lowest proportions, around the 91% of people that knew their HIV status. However, when it comes to being on ART, among those that knew their HIV status, similar numbers as awareness, and the highest in Boshanala district, as well as also moderately high in the viral suppression in the province, in the district of Ngaka Modiri Molema. Now, we have spoken about people that are living with HIV, virally suppressed, knowing their HIV status. Okay. But I think the statistics that we need to pay particular attention to is those people that actually are on the other side of the coin. People that do not know their HIV status, people that are not on ART, people that are not virally suppressed. That is the gaps, so that we can identify who are the people that we need to identify and also get them to know their HIV status. Now, looking at the first graph, that is the people who are living with HIV. So it says percentage among people that, so the base is among people that are living with HIV. We find that by age group, those that are 50 years and above may contributed about 25.7%. So that says among people that were found to be living with HIV, almost 26% of them were those that were
7% to 32.2%. Now, looking at the consistency of condom use with the most recent sexual partner, in the province we'll see that more than a half of our participants reported that they've never used condoms at 50.7%. And 21.4% of our participants reported that they used condoms every time with their sexual partner. If we look in terms of the districts, once again, Dr. KK, or those residing in Dr. KK, reported, more than 53% reported that they never used condoms, followed by both Bojanala and Ngagamodiri Molema at about 48%. And then in terms of using condoms every time with the sexual partner, all the districts are, they reported similar proportions between 22 and 23%. Now moving on to circumcision, self-reported circumcision amongst male aged 15 years and above. At national level, self-reported circumcision has increased from 60% in 2017 to 63.7% in 2022. Specifically in Northwest, we observing a similar pattern where the numbers of those who are circumcised or reporting being circumcised have increased from 50.9% in 2017 to 60.8% in 2022. If we're looking then in terms of the demographics, more of those younger males in the age group 15 to 24 reported being circumcised at 74.6%, followed by those in the age group 25 to 34 with, at 66.7%. In terms of locality, we see that more of those residing in the rural informals reported being circumcised at 66.5%, followed by those in the urban areas at 58.2%, followed by those in the rural formal at 44.8%. In terms of the districts, we see that more males residing in Bojanala actually reported that were circumcised at 65.1%, followed by those residing in Ngagamodiri Molema at 61.3%, and then those residing in Dr. KK at 53.6%. Now looking at circumcision type, meaning that looking at medical circumcision versus traditional circumcision. We see that at national, more males reported that they were medically circumcised at 60%, compared with those who reported that they were traditionally circumcised at 39.2%. With a similar pattern as well in the Northwest, where more males reported that they were medically circumcised at 66%, compared to those who were traditionally circumcised at 33.5%. In terms of the age groups, we also observing a similar pattern, where in all the age groups, the participants reported that, more participants reported that they were medically circumcised compared to those who reported that they were traditionally circumcised, except for those in the age group 50 years and above, wherein more of those reported that they were traditionally circumcised at 52% compared to those medically circumcised in that group at 47.8%. In terms of locality, in urban areas and as well in the rural informal, more participants reported that they were medically circumcised compared to those who reported that they were traditionally circumcised, except for those then residing in the rural formal or farms, where in those areas more males reported that they were traditionally circumcised at 54.5%, compared with those who reported that they were medically circumcised at 45.4%. In terms of the districts, once again, a similar pattern is observed where in all the districts, more males reported that they were medically circumcised compared to those who reported that they were traditionally circumcised. In Bojanala, those who reported medically circumcised were 58.1% compared to 41% of those reporting that they were traditionally circumcised. In Dr. KK, 70.8% reported that they were medically circumcised compared to 28.6% who reported that they were traditionally circumcised. With Ngaka Modiri, Molema, with 77% of males reporting that they were medically circumcised compared to 22.7% of those who reported that they were traditionally circumcised. Now moving on to awareness and uptake of PrEP amongst people aged 15 and older. 30% of our participants reported that they've ever heard about PrEP in their life, and 5.1% reported that they have taken PrEP before, and 1.6% reported that at the time of the survey they were taking PrEP, and 79.5%, almost 80%, reported that they would actually love or like to take PrEP for prevention of HIV. Then moving on to HIV testing amongst people aged 15 years and older, starting with females. Those in the age group 15 to 24 years, amongst females, 76.3% were ever tested in the past 3 years, with 19.7% in that age group reporting that they were never tested. In the age group 25 to 49 amongst females, 84.6% reported that they were ever tested in the past 3 years, with 2% reporting that they've never tested before. And in the age group 50 years and above amongst females, 56.2% reported that they tested in the past 3 years, with 19.2% reporting that they've never tested before. Moving on to males, starting with the younger ones, age group 15 to 24, 50.5% reported that they've tested in the past 3 years, with a concerning 34.2% who reported that they've never tested before. And then in the age group 25 to 49, 67.2% of males in that age group reported that they tested in the past 3 years, with 14.2% reporting that they've never tested before. And then lastly, in the age group 50 years and above, males in that age group, 53.6% reported that they've tested in the past 3 years, with 20.8% reporting that they've never tested before. Thank you, and I think I'll give over to my CDC colleague to continue.
Good morning, colleagues, and all protocol observed. My name is Pelagia Mrangandi from CDC, and I'm going to take you through the last remaining slides. Oh, I'm going in the wrong direction, sorry. Okay, so just in conclusion, from the data that was presented, we see that there is a shift in the HIV epidemic curve towards older age categories, which signals a stabilizing epidemic. We also see that there has been a marked increase in ART coverage, viral load suppression, and progress towards achieving the 95-95-95 targets in the province. But although ART coverage and viral load suppression increased from 2017 to 2022, it remains lower among males and those residing in urban areas. We also see disparities in the burden of HIV, with HIV prevalence 2.5-fold higher among females aged 15 to 24 years and 2-fold higher among females aged 25 to 49 years at 29% compared to males of the same age groups. We also see subpopulations overrepresented within gaps in the clinical cascade, and these include adolescents and youth aged 15 to 24 years and people living with HIV residing in urban areas. The prevalence of male circumcision among those aged 15 to 49 years is at 62% in the province, which falls below the national target. But we see that majority of circumcisions are medical at 66%. We also see that PrEP awareness at 30% and uptake at 1.6% was universally low across districts. However, it's encouraging to see that 79.5% of participants indicated that they are willing to take PrEP to prevent HIV. And with these, some of the actions for consideration that the province can look into include a long-term strategy to cater for individuals in an aging HIV epidemic. We saw that the epidemic curve shifted to the right with more higher proportion of the higher HIV prevalence in older age groups. And heightened focus on campaigns such as U equals U and other strategies to promote uptake, sustained use of ART, especially among young people, adult men, and across key localities. And tailored interventions to address gaps in the clinical cascade by district, locality, and subpopulations. And continued focus on increasing coverage and demand for medical male circumcision among males aged 15 years and older. And finally, enhancing accurate public awareness and demand for effective HIV prevention measures, including regular HIV testing, condoms, and PrEP. And with that, would like to thank the people of Northwest for opening their doors to the HSRC team during the survey. And these field workers who were saying thank you to the South African people for opening their doors. Thank you. And this work wouldn't have been possible without a consortium of partners led by HSRC, and this includes the US Centers for Disease Control and Prevention, CDC, South African Medical Research Council, SAMRC, National Institute for Communicable Diseases, NICD, University of Cape Town, National Department of Health, South African National AIDS Council, United Nations Children's Fund, United States Agency for International Development, USAID. And the funding source was President Magen's Plan for AIDS Relief, PEPFAR, through CDC, and we are grateful for the funding that they provided for the survey. And to all the contributors to the survey, thank you very much.
Can we please give them another round of applause? Thank you very much, Professor Zuma. Yes, Professor Zuma. Yes, Professor Zuma, and the team for the facts that you presented before us. You know, this reminded me of the book by Hans Rosling, where he's talking about factfulness. Clearly, the statistics here helps us to transcend from perceptions to facts. And this is the reality that we're living with in Northwest. Much work needs to be done to improve the situation. Colleagues, we are now going to move to examination. You know, researchers will always do research, even if when they present research findings, they also continue to do research. They are very inquisitive people. So now you are going to write an exam, and each and every one will be assessed to see if you've been paying attention. Each and every one of us here. We have got a list of questions, colleagues, on your tables, and in each table there is a colleague from HSRC. Just raise your hand. Just to make sure that each table has got a colleague from HSRC. It looks like other tables do not have. Okay, okay. Copy and paste. Okay, we will make sure that each table has got a colleague from HSRC who is going to help us facilitate answer the 4 questions that we have. Each question has got a subset of questions. Please do not write a dissertation. Go straight to the point. The first question, here are our questions. So please work as a team, and once you have answered all the questions, each team or each table will have a rep to come forth and present your responses to each question. Please do not take more than 4 minutes when you present your reflections. And we are going to allocate each table 45 minutes to work on answering the 4 questions facilitated by members from HSRC. As you start working on answering these questions, please feel free to grab a cup of coffee at the back, then you can start working. Grab a cup of coffee, then your 45 minutes starts now. So after 45 minutes, table 1 must be ready to present. Thank you very much. Give yourselves a round of applause.
Bagaetsu, afternoon, colleagues. Just to note that we are starting. So those that are just networking with colleagues, if you can just go back to your table. An HSRC colleague has been allocated to each table, so we'd want us to just engage on the specific questions that have been allocated to your table. As it was mentioned earlier on, we only have 45 minutes, and we know from having engaged with others that as we start, there's a lot that you'd want us to cover. So we want to ensure that you have enough time. So please just go back to your table. There is someone there waiting for you to then engage with. Thank you. us. They'll just indicate the question number that they responded to and how they reflected on it.
Okay, thanks very much, Chairperson. Table 6, we dealt with question number 2. Apologies. Our question is question 2. What HIV messaging is critical to communicate and to who? The sub-question is, how do we reach and empower adolescent girls and young women? And where should we focus and how? So we said, because we are talking about young people, first and foremost, we have to think the way they are thinking. And we also have to move with times. And as we can realize that youth of today is no more be acting or doing things the same way as the youth of the previous times. So we said we still have to go back. Okay, briefly let me take a background to say, previously we know that they were messaging and they were talking about HIV, whether prevention, whether testing, everywhere. And that has sort of slowed down. So we are saying we better go back to looking at the places where we find young people, where young people are getting more joy, more vibe to be. We're looking at the entertainment where we say it's better to reach at them, at those entertainment spaces, and making sure that, for example, if there's something like what we said, festivals and those all white, whatever that they attend, and the Dukes on Flicks, we make sure that we have a messaging at that platform, sort of maybe getting something like a banner, like with all the messages around the HIV/AIDS prevention, the treatments, and also encouraging behavioral changes amongst them. Also, we also need to go digital, as looking at the social media platforms, where we also said within those very social media platforms, we have to check which, what are we calling them? Which areas do they like most, even if it's about TikTok, about Instagram, what exactly do they look for in those platforms, and make sure that for every one that the young people likes, we promote something like an advert, pop-up messages that if they are going to look at the dance competitions within is the TikTok? They've asked the elderly to present for the young people. So yeah, whenever they open those platforms, there's something that pops up that's talking about HIV, STIs, and prevention messages or social behavior changes. Okay, also the peer-to-peer conversations. The other thing that we thought of, which is mostly coming up now, is the podcast, that maybe there should be some podcasts where the subjects that are handled are around the prevention, the treatment, and the viral suppressions and the behavioral changes. Okay, we also thought about the churches, because some youth are mostly in those religious spaces, targeting them, because within the very same churches there are peer educators that can be trained and be encouraged to work with them, especially on those religious camps that they are attending or the conferences. Then empowering with resources, looked at something like our point system. Okay, we took advantage of Dreams sitting here, looking at what they are doing at the present moment. As they are registering all their clients digitally, and they are kept in their systems, and as much as they are accessing the services, there's the point systems that they are collecting points, and at some point they can use those points either for things like data, sanitary pads, and then, yeah, that, and then the role model, we spoke mostly about the social media influencers, and also the peer ambassadors. And we also said, when looking at those social medias, it's critical to check and have maybe a conversation with those social media influencers so that they can send the proper messages, the messages that will also benefit our programs also. And yeah, even this, remember, we have events within all the departments most of the time, because we were looking at the finances, because sometimes the social media influencers, maybe if you say somebody must do a 2 minutes, 5 minutes clip for what that person might look for money. But we were also saying during the events, there are quite a number of entertainers and those influencers that are used. Maybe we can include within whatever they are going to perform and ask them to also include something like edutainment around testing, treatment, and viral suppression. The last question was saying, yeah, this was the most difficult. Has U equals to U being successful in the province? What could be done to further this campaign? This was very heavy for us because we thought maybe somebody can help us to understand, or is U equals to U being accepted within the province? Has it been embraced, and has it been launched? Because we think those are the things that can assess, and so that first it has to be accepted, it has to be launched within the province, and so that there can be messaging that can be sort of publicized around U equals to U, so at all platforms. So thank you. Maybe we can be assisted on that one. Thank you. Sorry?
Okay, colleagues, so the issue of addressing U equals U, we can address it when it's your turn, but I just wanted to her to introduce herself and the organization that she comes from before we move on to table number 4.
Okay, thank you, Chairperson. My name is Puselezo, my surname is Mohapi. I'm from PEPFA. I'm the PEPFA provincial liaison supporting Northwest.
Okay. No, thank you so much. We will move to table 4 and then table 7 will follow afterwards. Thanks.
Good day, colleagues. My name is Ethel Maselesele and I'm from Social Development. I am with Right to Care, the Oram Institute, CDC, Margaret, and yes. So we were responding to question number 4, which talks about success and challenges in reaching youth, women, and other populations. And the first question, it says, how do we influence changing patterns of prevalence among adolescent girls and young women? And we talked about programs that mostly are developed for the target group without them. It's not all of them, because we are having other evidence-based programs, social and behavior change programs, but because of resource intervention for impact versus the high targets that are set, it compromises the quality of those programs that we are implementing. So we need to ensure that quality messaging in our interventions. How do we better coordinate efforts on health intervention strategies at local levels in South Africa. We acknowledge that so much work it is done, but we need to integrate our services. We made an example of the model that Dr. KK Ramotosola, I'm giving you badges. The model that Dr. KK is implementing, where you are having all the stakeholders in a room when you go to your event, that there is no service provider or a government department that go to a community alone. And because of that integration and the accountability, Ramotosola is here. If a department is not there, if a service provider is not there, because he knows them, he calls, where are you? We are in a meeting, because each and every service provider needs to account. So we need to improve on integration of services. We also need to improve on follow-ups and also to decongest facilities. The other issue is integrity of healthcare providers. We talked about the attitude of individuals that prohibit communities to be able to access services within their localities as well. We talked about being client-centered in our interventions, to say that if a client can choose to say, as much as I'm staying next door to the clinic, but I don't want to receive my service here, that we need to be able to cater for what the client is saying. But sometimes we know that it is because of the attitude of the professionals that are providing services that are a barrier to ensure that our communities are able to economically access services. We talked about the quality of care versus the numbers, of which link to number one, linkage, successful linkage to care and referrals. If we do not know each other as stakeholders, and if I'm referring a client to Home Affairs or to SASSA or to health, and I'm not referring to a specific person, I'm just referring randomly, I have not engaged anyone to say, I'm having this kind of a client, they're in need of the service, can they come, when are you available? Then where I am referring to, they will not be able, they don't expect that person. So sometimes that person is lost along the way, because there is no person who's going to say, our person, our client did come, we were able to do this and this and this, so that there is continuity of care in that person's life. Also, we talked about improving of mapping. And we are saying that some work is done, but we need to improve on that, because when you are having developmental partners come, because they're having a mandate of a certain service with a target, they are going to find an easy way, or where there is a huge number. And we have seen even in our stats, it was presented, rural of rurals and farms, they are disadvantaged. So in our mapping, there is also need to be improving to go into rural areas. Oram, they are here, they are having resources. They know local facilities they don't have to be able to reach those further areas. So we need to ensure that as partners they come, we are able to direct them where services are not congested as yet. Number 3, how is HIV testing and status awareness at and viral suppression seen in your community? Yes. Okay, we talked about the fact that when we are having, if I'm in a relationship with my partner, when I am HIV negative, they take themselves as HIV negative. So they will test, So we need men to be able to access healthcare services. And it does not necessarily need to be good clinicking. It can be good doctoring or our developmental partners. But we have realized, because we have been having engagements that are led through the House of Traditional Leaders, where we are engaging in communities to say sometimes the message that we carry out to communities, it does not really reach men in their simplest understanding so that they can be able to apply it in their lives. So we are having men engaging in the safe platforms. We are providing your Men Championing Change programs, your men sector program. We also talked about the happy hour for men, but the challenge is that men would mostly likely want to engage with a man. And in some instances, we don't have sufficient male clinicians or sufficient facilitators who are males so that they can be able to just pour out their issues in a manner that they don't think that we will impose our views as women. Okay, I think others, maybe 1 minute if I'm missing something. Good. Others, they will come on writing. Thank you very much.
No, thank you. And then just to slap the team and the team that presented before. So just to note that the presenter should just stand up so that they are able to be seen by the colleagues that are also connected online. And then you just need to introduce your name, your surname, and the organization that you come from, and if possible, just the organizations that are represented in your table. So we are going to have table number 7, and then we don't need to repeat what is already being said, just something new or different from what was mentioned, and then we'll take the table that is ready after table number 7. Thanks.
Good day, everyone. My name is Kyokhomodi Tlhagane, and I am from Office of the Premier. So the question that we are addressing is, what needs further strengthening in the province or district program? So we have used the questions as our guidelines, but like we have other issues which there aren't any sub-questions about them here. So the first one that our team has noted is that attention needs to be given to the 15 to 19 age group, as these are our teenagers, high school, and the future leader or society. So DOE, in collaboration with health and NGOs, need to be involved. HIV and HPV needs to be taken to schools. So our second point is, the problem is that partners come and go. This is a big problem because they start very nicely, but then they are not sustained. The same situation is with the administrations, as they come and go and programs are not sustained. The third one is, there are programs that concentrate on school-going kids, but what about the out-of-school kids? Of the 8 people in this table, only 2 knew of the DREAMS program. Apparently there's like a DREAMS program for girls. So boys, do we have anything that is like more targeted to boys at the age of 18 or 15 to 24 years? I don't think we do, but only 2 of like our members knew about DREAMS program, which shows the poor advocacy of the program. We need a DREAMS for boys program targeted at 15 to 24 years old as well. There are limited programs available for those not engaged in sexual activities as well. Our next point is, funding for outreach campaigns has decreased. What is needed is prevention campaigns, regular HIV testing, at initiation and adherence campaigns. People, communities respond better to campaigns Campaigns can be in malls, parkings, schools, social gatherings, events, and churches as well. Program or campaigns need monitoring and evaluation to ensure that proper spending is happening, no corruption, and the proper work has been carried out or delivered as well. DOE, DOSD also need to budget for HIV programs. Okay, there must be better coordination between DOH, DOE, and DOSD when it comes to HIV. A lot of times we find that it is quiet in our province when it comes to HIV campaigns, but I think it is because that there are limited available funds for such campaigns. So we do need like more organizations to fund for these campaigns as well. We need to strengthen our cross-border health programs to target the truck drivers as well, the incoming and outgoing of the trucks. Parents need to be empowered or well-trained to be able to also have a transparent relationship to talk to their kids about these situations or issues. Also, we have a problem with Dr. RSM district does not have partners nor partner programs. This is a gap. It is said that it's because of the data, but the people of RSM work in other districts and come home to Dr. RSM. It also the most rural district in NW. So yeah, that's all. Thank you.
Thank you very much. Another round of applause. I wish Treasury was here to listen to the issue of funding. Any table that is keen to present, that is ready? Oh, 7 hands in this table.
Good day, colleagues. My name is Namezo Segomoto. I'm from the Northwest Department of Health. Here in our team, we are having a rep from a mining sector, a rep from civil society, a rep from University of Northwest, and a rep from Office of the Premier. So we were addressing health. I've mentioned health. We are 2 from health in this group. We were addressing number 2, and the question was, what HIV messaging is critical to communicate and to whom? And we have 3 sub-questions that we were expected to respond on. So I will just go to number 2, and I'm happy that most of the issues were covered by the latter speakers, so I will just go straight to the ones that were not mentioned. Before I go to number A, as a team, we've agreed that it's time that we include boys, like you've just said, in our interventions. Because based on the statistics that was presented in this meeting today, we've seen that somehow the statistics for boys and men is actually going up. So meaning that we need to come up with both interventions or targeted interventions for both boys and girls or young girls. So, and then we also agreed that we need to strengthen multi-sectoral approach when dealing with our young people in the province and do away with a silo mentality. The other thing, we've also mentioned that, like I've said earlier on that, like you said, that already we're having programs that are in place, meaning we are having messages in place. We're having Dreams project that actually you've seen that it has been working in the province or across South Africa and other countries. So meaning that messages are there. HIV prevention messages are already in existence. So but the issue is the approach on how we communicate the available messages, HIV prevention messages. So I will be going straight to the key interventions, others were mentioned. We talked about that it's time we include activities like music, drama, and use of pictures to communicate messages. We agree that, most especially in our province, we've been mainly focusing on events, dialogues, and other interventions. But it's time we strengthen these other ones that I've mentioned, because others were mentioned by our colleagues in the meeting. So under number A, they are saying, what are the implications of shifting pattern? Number A, ours is 2, ne? How do we reach, pardon me, colleagues. Ours are, how do we reach and empower adolescent girls and young women? Where should we focus and how? So as a group, we've agreed that we need to empower them by ensuring that we include them in our activities. So, and then our empowerment has to include the eradication of poverty, job creation, and allow or encourage young people to be independent. Secondly, we said we need to use young people to reach young people. Normally, they will be saying nothing for us without us. So meaning those dramas and everything, they have to be led and be done by the young people. And then we need to focus on areas where we can find young girls. We've been debating on this one of churches to say, when you go to most of the churches now, unfortunately, you'll find out that our young people are few in churches. So meaning we have to go out and find them. So where do we find these young people? We said, okay, they are at schools. And remember, at schools, we are having those ones that are sexually active and others are not. I like what the other group has just said, that we must also develop those messages of those that are not yet sexually active, so that they can also remain like that until they reach certain ages. And then we need to, we talked about the brothels, that yes, I manage the key population program in the province. And most of us, we know what is happening. When you go to those brothels, you'll find 14-year-old, 13-year-old in those brothels. So it's time we focus on such areas. Taverns, you'll find a 12-year-old. You remember an incident that happened, Eastern Cape, 13-year-old, and so those are the places to be targeted. And then they go to youth centers, and remember, some are not functional. And then clinics, they do come to the clinics, but the fortunate part is that in most of the clinics, we're already having interventions for the young people. We've got youth zones and others that others have just mentioned. And then we now go to the other one, number B. Let me mention the other one, or how to empower young girls. We said we need to influence city and town planning to include the restoration of youth clubs and centers that are not functional in our communities, like recreation centers with activities that can stimulate and keep young girls and boys at ease. And we also said we need to influence or change municipal bylaws to restore order within communities. Hence, remember when I started, I said we need to strengthen our multi-sectoral approach, because alone, as we are here working for social development, Department of Health, when it comes to bylaws, there's nothing that we can do, meaning we need to engage municipality so that other things can be strengthened. Because when you go to those taverns, you'll find a 10-year-old there, 12, and then the tavern will be opened at 6 o'clock, 6 to 6. Such kind of things, those are the things that have to be regulated in our communities. And then we go now to the last question. The last question, they were saying, has U equals to U been successful in the province? What could be done to further U is equals to U campaign? So on this part, colleagues, I'll be giving Pastor Moepi to respond to this one. Over to you.
Ala chapel ke nna moruti ke le nosi ka ba. Ala nchapel matsogo. All right. This one is a very controversial one. I know it has created more enemies than friends. But what we said from experience and interacting with communities is that this program has been poorly presented and introduced and in the province. And it has been a highly contested terrain, something that also suggests that maybe timing was not right. At the time, while we're still trying to enforce and encourage continuous use of condoms in all sexual encounters, U equals to U came. Unlike MMC, which encouraged use of condoms, this one has been selfishly used to discontinue condom use by these partners. By the way, they don't want to use condoms, and research says they don't even know their status. Even if they know, they are not remaining on treatment so that they are virally suppressed. And as a result, we have these findings and people presenting more with sexually transmitted infections. What we said is that you should have been more about celebrating one's achievement on viral suppression than it is today. It is now more linked to bloating than what it wanted to achieve. And we said 3 key points must be noted. It has not been successful and should be revisited with more clinical assessment on those on treatment. It was poorly introduced, like we said, and messaging about it should be revised and properly crafted. Lastly, it has to be revisited and encouraged, especially for those people living with HIV and want to plan their family, than a generalized approach. Thank you.
Oh, thank you very much. Pastor, the table here was very keen. Oh, okay, let me give these ones, then you'll be next.
Thank you so much, Program Director. Standing here, colleagues, it's Bonolo Mutlomi. I'm coming from Shout It Now. And our table here is having representative from PEPFAR, Dr. RSM, District 8 Council, and myself, Shout It Now, HIV SA, as well as Bojanala, District CSF Chair, and also Office of the Premier. So we were answering question number 3, what needs strengthening, further strengthening in the province or district program? And it consists of 3 questions. What has been the results of voluntary medical male circumcision program, and have youth HIV prevention campaigns been successful at reaching its target audience? And lastly, have HIV prevention strategies for men been successful, and what are the best practices to focus on? Colleagues, I won't mention what has already been mentioned by other tables. I will just highlight some of the things, key areas that were not mentioned by fellow colleagues. So number 1, we said that, as the province, we need to start having conversations with men and just having a safe space where men can just sit as men and start communicating about men issues, issues around HIV, issues around GBV, issues around VMMC, issues around just family conduct, and also them having to advocate for some of the HIV prevention programs within the communities. So once we have those talks and dialogues with men, we know that that is where we need to start, because one thing that we want to achieve is to get men to access health services, and it's been a taboo. And what we know is that men usually want to test with their finding out about their HIV statuses from their partners. And we want to move away from that. And actually, once those dialogues or conversations are had by men, by themselves, they can be able to encourage one another to start accessing the health facilities and actually being advocates as well to younger boys as well. And one thing that we talked about in the table was the issue around VMMC, where we know in the province that we coming from different beliefs of how to do things, and from the data that was presented, we have seen that 50 plus men has actually conducted VMMC through traditional service, and younger men obviously doing, going for the medical way of VMMC. And we are saying that we need to also have conversations with men around that so that they can also keep encouraging the boys to go via the medical route, because that is the only way that we can know that it's safe for them to go through. And it was also mentioned the issue of reaching out to truck drivers, but we also touched on farm workers, because we know that or we have seen that in the facilities, men, or in the province, men go to farm working. And wherever they are, it's very, they can't access those health care services at the farm area or the rural area. So we are saying that we need to also take, consideration to taking the services to the farm areas. And then we are saying that for men to, get the men to come and to access the services, we need to reinforce our index testing as a province. We need to, maybe encourage or speak and have that conversation. And I liked what the other table was mentioning about posters and, communication, where we just need to not just say it, but also if it's in a picture form, then we can be able to, or posters, they can be able to know that this thing is really possible for myself to test with my partner. And we also mentioned issues around Zikhala Kanjani. We are saying that as a province, we do have very good concepts of getting the youth accessing the services and, communicating. But we are saying that we need to really strengthen that component, because if we just launched and it ended there, then it means that we are really not serving the objective of the main program. And we are saying that also the facilities, we need to strengthen the youth zones, as well as the AYFS services. Colleagues, when we say strengthen, and we are talking about not just me as a youth going to facility and knowing that there's a safe space, but we need to maybe have ideas or things that can really draw the youth to come to the facilities. If it's a gardening service that we need to have in the facilities, let it be that, because we'll know that from that gardening service, a young person or man or whoever that is interested in farming, they can be able to learn from, that small little garden at the facility. And, the youth of Northwest, we are faced with unemployment, and if we strengthen the youth, youth AYFS facilities, where we can just maybe have, it's one of the ideas that we can have an internet where youth can be able to just source out available opportunities for them, so that they can be able to know where they can apply for employment or other opportunities, whether it be applying at a college or university to further their studies. But something, we just need to do something as opposed to just looking at the health, because those are some of the things that are drawing the youth to come to the facilities. But if we are not addressing that, colleagues, then it means that we'll still have those gaps of the youth not going to the facilities, and especially men. Thank you.
Thank you very much. As a father, the word man keeps on, coming up. As a father, would you really say to your son, do like I do?
Just in time. Good afternoon, colleagues. I hope everyone is still okay. So, in this table, I have with me the leadership. I'm going with the leadership in this table. I have the DDG. I have our chairperson from civil society. I have UNAIDS, and I have USAID, and I have TB, HIV, and care. So you can see this is a table of leaders. So the question that we are tackling is question 1. What are the lessons learned in the province? I hope this is not too much for you guys, because I have a loud voice and I usually don't use this. So the first one, on the 1, it says, what are the implications of a shifting pattern of HIV prevalence and the aging epidemic? So on that one, as this table, we figured that the presentation there stated and showed us that there's a decline in the prevalence. But then we were discussing what could have caused the decline. Is it change of behavior maybe? Or is it because of the presence of partners? Or is it because of easy access to treatment? So maybe as a team here, when we look at it, we can look at all those issues, whether they are the ones that are leading to the decline. And then we saw again older people being the ones that are living longer, which means that older people are adhering to treatment. And not only adhering to treatment, we saw again that it might be that they now have more access to knowledge than before. And therefore now they access treatment and they remain on treatment, unlike our youth. And then, and it can be very distracting. Sorry, colleagues. So on that one, we saw again that there has been a shift on 0 to 19, and the presence of HIV amongst those 0 to 14, and this calls for intervention such as PMTCT to be scaled up. And then we still continue on the first one. So we say for those 15 to 19, we need strengthening of programs such as PrEP. We need also programming strengthening of programs when it comes to condom use. we saw there that condoms are not used, especially between the ages of 15 to 19. So another gap or limitation that we saw there is that the study does not cover RSM. It serves as a limitation because the RSM is mainly a rural area, and therefore in the presentation it was not covered, which then leads to the limitations of the study. And then another thing, we need to improve on retaining patients on treatment, and then we need to ensure that there is adherence and there is viral load suppression, because we saw that, or we see that as a province we are lagging behind when it comes to the UNAIDS 95-95-95 strategy. So there's also a need to develop a longitudinal view of patient medical record to monitor client movement across all provinces. So what we agreed on this one is that if I am a client, I should be able to be seen go Eastern Cape that I've tested HIV positive and I'm from this province and I've been on treatment, or I have not been on treatment. So when I go to other provinces, it should be easily picked up that this is so and so from this province, they previously tested negative or positive, such things. And then the second one said, where do you and your children or community learn about HIV at school or clinics? So we mostly focused on ages 15 to 19 and 10 to 14. So it means we were looking at youth. And we were saying, where does our youth access information? The answer is most of our youth, they access information in schools because they are there. The age that I've been talking about, 10 to 14, 15 to 19, they are all in schools. What programs do we have in schools that talks to prevention of HIV? In primary schools, there was someone who said, I don't think there is programs in primary schools. Well, maybe there isn't enough, but what we have currently, it's Soul Buddies. So Soul Buddies, it was an initiative by Soul City, but the department then took it over and is implementing it, and it has age-appropriate, scientifically proven information that is given to our learners. And then we also have comprehensive sexuality education, which strengthens life orientation program. Although we are saying we are not referring to the LO when we say teaching learners about HIV, comprehensive sexuality education strengthens life skills, life orientation, because if life skills, life orientation is not taught correctly in the classroom, then we don't have learners that knows that there is sexual reproductive health services that they can access. And then we also have peer-to-peer clubs, which is peer education. That is in our secondary schools. And then all these programs that I'm talking about, they also need to be strengthened. Why? We find ourselves that these programs are run by educators, and we all know that educators are already have a lot on their plates. So this is the programs that needs to be strengthened, because then it means in some schools we'll have educators not being available. And then we know of the integrated school health policy that requires Department of Health, Department of Social Development, and the Department of Education to work in partnership to ensure that school health is attended to in our schools. So with all these programs that we're having in the schools, our children are learning HIV and AIDS information from there. But however, we have seen, we are not yet there. Condom use, very low. Early sexual debut, very high, especially among boys. And I tell you, in our camps, they say, Hagiji stock sweetie ka plastic. So we are still far on that one. And then parents, where do our parents or our communities learn about HIV? We have partners, but we still believe that that is not enough. We need to bring back parent engagement. We need to bring back parents' dialogues. There were times when we had dialogues with both parents and children in the same place so that we are able to discuss these things. So you find now a parent, motsamaisa tirwa ke re la ba itse ko funeral mbare. So motsamaisa tirwa re na ko child. Untshutisa se funeral. Then number 3 was men programs. Are they successful? The answer is no. I think most of the tables have presented on that we do not have men programs that are successful. And then my colleague mentioned that there are programs as Mina and Coach Impilo for men. And then at least in Northwest, we have men-to-men done by Shout It Now. But we all know that the programs that are offered by partners, they are limited. So probably our gap here is funding. There is a need for more funding because we can't have partners only in Bujanala. And someone was saying, probably in Bujanala, we still see Bujanala as a district, there's high prevalence. Kanti, it's because of the data that we are now getting, because we have a lot of partners there. So it means we now have a lot of reports. In RSM, wouldn't know, because there's nothing. Thank you, sir.
My apologies. A round of applause. Another table ready. Professor Zuma, it looks like you'll be going back to Pretoria with that present that you were showing me outside. Because thus far, nobody has hit the 4 minutes or less in terms of reporting.
Thanks, Chairperson. Let me do that. I'll do it in 1 minute. My name is Akanyan Didimalang. I'm from Department of Health, Dr. RSM. With me, we have Prof. from the university, PCA, and Live. Oh, Laugh Line. Thank you very much. We are doing question number 2. I think most of the colleagues touched on issues that we have noted as table number 10. But the other thing that we also noted, we noted the issue of maybe making programs for young male and young men, of which I think Oslebo clearly elaborated on that issue. And then we also ask ourselves whether do we have adolescent programs or adolescents programs that are up and running. And through our engagement here, we have realized that yes, we have programs, but we are not reaching out. In the presentation, we saw that there is a rural farm where there are also numbers there, and in some instances, those numbers are very high. So it means we are not reaching out to farms and rural areas, or let me say the hard-to-reach areas. I think most of the things they were touched by other groups in terms of empowerment. They also touched, except that we said we need to do what what is called knowledge, attitude, and practice study to make sure that our empowerment to adolescents and young women are yielding result by doing knowledge and attitude practice study through Facebook. It can be easier if we do it through Facebook, where we will be monitoring their responses in terms of knowing whether is there having knowledge in terms of HIV and AIDS, or their programs, their attitudes towards that, and the practices. So, I think other things were touched by other groups, Chairperson. I don't want to waste your time. Thank you very much.
Give them a round of applause. 4 minutes on the dot. It looks like the car will be staying in Mafikeng.
Good day, colleagues. My name is Dorothy Ramono from the Department of Education. The question we had was, what are the lessons learned in the province? The first point we had was, we wish that the key populations could be included in such a gathering. And we talked about the sex workers. What we have learned is that they do receive health education, but the use of condom is still very low. And the question was also asked, are we doing much in awareness of how our sex workers should be conducting themselves? And the response was that the sad part is that even the learners that we are talking about, who are from the age of 15 to 19, are also now entering or migrating to the sex worker sector. So it seems like much is done, but more damage is happening to our little ones. And we should also include the inmates, the LGBTQIA, and the drug users. And it was alluded to the fact that in terms of the sex workers, communication has been done with the providers, the clients, and also access to PrEP, so that HIV should be going down. But now that we know that it is all done for all the sectors, we just need more strengthening so that our sex workers are safer and they can live longer. And the second point was our adolescent and youth. We talked about the 15-year-olds to the 19-year-olds. We are saying the Department of Health has activated adolescent youth-friendly services. Whatever they did not receive nor understand in the classroom in terms of comprehensive sexuality education, they are free to go to the adolescent youth-friendly services between 2 o'clock and 14 hours to 16 hours. They call it a happy hour, where we are provided by a very youthful thinking and talking nurse. So most of our children are having time to talk their sexuality issues or even sex issues and HIV issues. We also have our partners like Shout It Now. Through the agreement of the parent body of the school, they are allowed on site to offer services, sexual health, reproductive, to our learners. And the first thing that is expected of them is that there should be consent form signed, so that should anything untoward happen, the children and all of us are protected. We agree that integration of HIV and AIDS is done nationally from our Department of Basic Education through scripted lesson plans. So we are talking sexuality, we are talking transmission, prevention, a decreasing of HIV and AIDS in the classroom. And the last thing that what is happening in our schools is that all this has been done for our learners, but now the floor is now going to be opened for parents and learners to talk sexuality, HIV and AIDS, and prevention of pregnancy under the same roof on the same platform. Thank you.
A round of applause. 4 minutes, 33 seconds. They are just 4 minutes behind table 10. Just 4 seconds, actually. 4 seconds behind table 10. They were almost there.
We are done, actually. Let me prepare myself, sorry. Greetings, ladies and gentlemen, colleagues, all the protocol observed. My name is Mildred Maropefela. I've been coerced to present, actually, by virtue of me being a chairperson. I was coerced. I need to share that with you. I'm not doing this voluntarily. Under duress, my man, under duress. In my team, I've got AFSA, one representative of CSF, NMM, Ngaka Modiri Molema Municipality, Department of Health, and PCA. I think we are the last table to present. So clearly that is given that 4 minutes will be too much because they have already mentioned a lot of things that we wanted to mention. We were addressing the last question, question number 4. We're going to start with point A. Can't we? Okay. Ish. Okay. The first question, how do we influence changing patterns of prevalence among adolescent girls and young women? Point 1, we need to accommodate awareness programs on HIV-related issues to the level, to increase the number of awareness programs on HIV-related issues to the level of adolescent girls. Enhancing comprehensive sexuality education, it was spoken about through social media and in the households. Ensuring that there is access to condoms and contraceptions. Strengthening the youth-friendly health services and strengthening economic empowerment. Without economic empowerment, nothing we're going to do. Peer education support, gender-sensitive health services, especially for women. And lastly, strengthening of the PMTCT. Now, the second question to that was how do we better coordinate efforts on health intervention strategies at local levels in South Africa? And we said we need to get systems in place, e.g. standard reporting template, recruiting people who are representatives of the community to coordinate health interventions so that the refusal of participation in programs/surveys can be reduced. We are talking about community-led activities. And lastly, recognition of NPOs. That will mean funding of NPOs and etc. And the last was how is HIV testing and status awareness and viral suppression seen in your community? And the answer was that there's still stigma regarding HIV despite the awareness programs. There's been improvement in HIV awareness, lots of awareness programs in various activities. Second last, in clinics, there is a line for chronic patients, which leads to people stigmatizing the patients based on the assumption that they are HIV positive. Some may not be on ART consistently. Need to know, I thought it was the second last, still going on. Need to know who the target for the intervention is, how to approach them to increase awareness, testing, and etc. There needs to be a youth ambassadors. I think this point has been reiterated many times, who can speak on their HIV status as representatives of youth community, youth by youth. Some parents still don't inform their HIV positive children while they are taking the medication. Children need to be aware of their status too. So I think I want the present. I heard that there's a present for people who keep time. Thank you very much.
A round of applause. Doc, unfortunately, table 8 and table 10, it's a tie. Exactly same time, so we will think how we deal with the present, with the gift. But they presented exactly 4 minutes, 38 seconds, both of them. Colleagues, there is so much that is being done in the province. All departments are doing so much. It is just that we are not there yet. And we do appreciate efforts, programs, projects that you all have in place in partnership with private sector. But we are not yet there. The results clearly shows us that we are not yet there. But this session gives us an opportunity to harvest ideas. Because going back to our offices, we have then the opportunity to say, how do we improve? How do we intensify? How do we innovate to be more impactful? I always argue, we can have minutes, meetings, present our progress reports, 100% achieved, targets, clean audit, all those excellent reports that we present. But the question is then what? What is the impact on the ground? And I think that is one thing that we must always grapple with. To say, in everything, when you wake up in the morning, go into your work, come back home with an answer to then what? Yes, you've been in the office, sitting in that nice chair. Wile Sekgowa, you spoke English very well, but then what? How has that translated into changing the lives of the people in Northwest? So, with those few words, I am going to hand over to Doc to wrap up the program as we move towards the end, and thank you.
We're still hoping to end the activities by 2:30, so we really have a tight timeline. But I'm going to ask House Margaret to just share some of the reflections on the activities that transpired today. She'll also be joined by Meg Girumuditswe Molemani as well. And then I see your hand. I'll just attend to it, but just to allow these colleagues, and then we'll come back to you. Thanks. Okay, as the colleagues are...
How, boss? That's what I got when I start again. Good day, colleagues. Good day. Oh, I thought you guys are sleeping. Okay, my name is Judy Molemani. I'm working for the Northwest Department of Health. I am responsible for the ERT program. I'm standing here representing Meg Tsile, the Chief Director. Let me start by saying we thank you, Human Sciences Research Council, and then we thank you for the study that was conducted. We appreciate the findings that were presented to us here today. We also have heard the presentations as it has been made by colleagues from different tables that are sitting here. As Northwest, we are seeing that there are some inroads and progress that has been made. When you look at the 2017 study compared to the 2022, it means we are going somewhere. We know that as a country, we have actually introduced the ART or the treatment program back in 2004. And ever since then, there have been developments because our ART guidelines have been changing since 2004 up until now. Last year, 2023, we are having new ART guidelines where we have actually adopted the dolutegravir-based regimen in the ART program, which was adopted in 2019. Now, with that, we have seen a change. Even with regard to the progress with our 95-95 targets, you can see that Northwest, for all the populations, for the first 95, we're standing at 96%. Now, for the second 95, we're standing at 84, as compared to where you saw in 2022 when the study was made, we're standing at 77%. But today, we are standing at 84 as Northwest. It means we are going somewhere. And then we can also see that with regard to the 30-95 also, we are going somewhere. So we appreciate these researches that are being made because they, as they are being presented to us as government, it means it makes us to develop new strategies to can actually address the pandemic. So we can see that we are going somewhere. Now we are seeing that the things have changed because back in 2017, the most affected population group was the young people, the young girls between 15 and 24. Now we can see that when you look at the sexuality bar, the age group that is most affected now is boys. So you know sometimes this problem of us focusing in one group and leaving out the height, we have been concentrating so much on the young girls and young women and young girls population, and we left out the boys. So it means now as government, we need to make sure that we address all the young groups, all the young people. So we appreciate this and we will act on the report. Thank you very much. God bless.
Thank you so much for that. Margaret, do you also want to share a few words before we move on to the question?
Thank you very much, Doc. Let me take this opportunity to really appreciate our people, from the People's Province, the people of Bokone-Bophirima, for availing themselves when they were called to come and hear what is happening in the Northwest Province. I'm humbled. I really want to appreciate all government departments, my colleagues from government departments, all government departments, health, education, Office of the Premier, Department of Social Development and Correctional Services that are here, colleagues from the municipality, colleagues from, I've seen someone from Mr. Kim Ernest from Impala Platinum Mines. I'm launching the private sector forum this month. So when you come next, Doctor, you'll find a fully fledged private sector forum for Northwest. So I really appreciate that. And to HSRC, you are always there to guide us. When we ask ourselves questions and we do not have answers, you always come at the right time. So thank you for sharing with us the result of the 6th survey on HIV prevalence, incidence and behavior. I do say, like Member Manager, that we have made strides as a province in terms of where we are coming from, but we should acknowledge that we have gaps that we need to fill, and we cannot fill them by business as usual, looking at the time left for us to be at, to realize the 2030 vision of the United States, of the United Nations, sorry. Now, because I'm focusing on CDC people in front of me, now I'm talking about the United States government, because America is just in front of me. So, of the United Nations. So, I don't want to go deeper into the study, but what I can say, Doc, is that we have acknowledged the gaps that we have with children and adolescents, with boys, gaps that we have with men in terms of us having gaps in terms of ensuring that men knows their status and they are initiated on treatment. Same to young people, that we really need to go out there and look for them and make sure that they are initiated on treatment. And thank you for addressing the issue of knowing your epidemic, knowing your status, because we are giving us some suggestion as to where these people can be, whether in rural or whether in urban or whether in farming areas. But we do acknowledge that in the Northwest, and together we are a team, as you see us here. We would put our heads together and see to it that, as DDG has said this morning, we put together a plan and process it through the right channels to address some of the gaps that we are seeing in this. We are a mighty team, and we believe that together we can do it. I don't want to go deeper into the reflections. Thank you.
No, thank you so much, Ms. Margaret, for going deeper, but not very deep. So before I call upon Dr. Sean Joster, who's the co-principal investigator for Sabbsm, I just want to acknowledge the colleague who wanted to ask a question, and after asking his question, we'll just go. Remember in the morning when we started off, we mentioned that we wanted to project the 3 questions that you responded to. We just want to look at your response only to the second question, which looked at the photo gallery. So we'll do that, but just for the colleague to answer the question and just look at how you responded to that as well.
All right. No, thank you very much.
Your name and organization.
Okay, thank you for allowing me to ask this question. My question basically, I'm Pastor Neomwepi. I thought I introduced myself earlier. I'm Pastor Neomwepi. I'm from the AIDS Council. All right. My question basically, it's centered around way forward. Who commissioned this research? What was the intended plan on the findings? Meaning, what did those who commissioned this research want to achieve? Where to from here with this research? I'm asking this question because there are lots and lots of researches that have been done, reports there, but it's like these are reports that are there for any person, whoever is interested in the report and stuff like that. So I wanted to check the value for money, really. Or when we did this research, what did you want to achieve? So that we are able to understand, or out of this room, what program of action must be put together. Thanks.
No, thank you so much for that. So Dr. Joster will also just touch briefly on that as he also does his closing remarks. Just to go back to the question that you responded to online around I'm just waiting for it to come up. I don't know what is happening today with technology here. So we asked, how did the image gallery make you feel? We've had colleagues going to the image gallery itself. We also displayed it here. And we note that some of the colleagues said it made them feel emotional. They felt powerful. They found it to be very engaging. Some of them felt that it made them feel sad. Our history as a country, so it reflected as our history in terms of where we come from. There was a deep sense of sorrow for some of the colleagues, mixed feelings, injustice, amazed at how far we come from and the pride that comes. And I think a lot of talk that we did today was around partnership, coordination, and how do we ensure that we strengthen moving forward, because we have seen what we are able to do when we unite. And then motivated, touching, super happy, hopeful is a word that is also shared there. So obviously these conversations don't just end as we end the program. During lunch, we are going to continue the conversations. We are going to even continue beyond today. We have formed new relationships and we continue
to share new ideas on how we can strengthen the work and partner better even in our communities. So Dr. Joste, if you can just come in and do the closing remarks. And I've also noted that in the province, the owner or the person that hosts you must also just do the final goodbye and also show you the direction in terms of where you should also be eating and drinking, whatever they will be serving you. So I'm going to ask our DG, Dr. Mawel, to also just a few words, just as a goodbye, but also just the direction in terms of the province as well. Thank you so much. And just to thank my colleague as well, because this is the last time that you'll hear me speaking on this platform, Dr. Marumo Musenohi. Thank you so much for the wonderful facilitation that you did today. We really, really appreciate it. Thank you, colleagues, and have a lovely afternoon if we don't get to speak again.
Good afternoon, colleagues. Thanks, Lelo, for allowing me to just close and say thank you on behalf of the HSRC and also our partners for welcoming us into your province, into the Northwest Province. This study is one of our biggest studies in the HSRC. We call it Sabbsm. We live and breathe this study. We have lots of wishful or grand visions of what the study can achieve, but our main focus is to provide information. So since the first study was commissioned in 2002 by the Nelson Mandela Foundation, and the idea was to do it routinely, just to measure because I mean, everyone is doing something in the country. There's lots of interventions, there's lots of things and stakeholders working on trying to prevent the spread of HIV. What this study aims to do is to track that intervention. Where is it working? This study identifies where there are areas that need specific intervention. And I think how the study evolved, in the beginning, we only test for HIV. So we could only tell you this is the prevalence of HIV in the country. That was it. Every time we do the study, and it's done every 3 years, the idea is to improve it, to add more information. For example, now we can tell you what's the prevalence of HIV in the country. We can also tell you how many of those people are newly infected. So we can tell you what's the incidence. We can also tell you now how many people are on treatment. We can indicate what is the viral load. So those things never existed before. And we are so proud of this study. It's the longest study that we are running with regards to HIV. And I think our main aim is to provide information, is to direct, hopefully to direct where people are working, to see must they make any changes. And we feel that some of the information that came out of the study has led to different types of interventions. For example, focusing on adolescent girls, and we are proud that it came from this study. So it has been commissioned. The first one was done commissioned by the Nelson Mandela Foundation, and with our partnerships now with CDC and PEPFAR, we are doing this every 3 years. There's already plans now to see how we can do it bigger, how we can do it better, because every round we try to improve it and to provide more information that can be used not only nationally, but within the province. And I think as the study has grown, in the beginning we only went to, I think, 10,000 people in the whole country. Now we are even able to talk about districts. We never could speak about districts. So hopefully at the end of the day, after many rounds, we can go to all districts and give information on all districts to help people plan and adapt, how they focus on how to tackle HIV. So that's in brief what our aim was in this study. But on behalf of the HRC and the partners, we would like to thank each and every one of you, both in person and those online, for coming to the dialogues. It's something that we never did before. We're visiting all provinces, and it's nice to see that engagement. But this is not going to be the end of our engagement with you. We are going to share the presentation. So the presentation will be shared with everyone, and that you can share it, with your networks. We're also working on a provincial report, and that will also be shared with the province. It gives a bit more detail, not only what was presented in the session, but also more information about your province. And our hope is that this is also a start that will, will improve our relationship with the province, that we can become a better resource for the province, because we're always doing research. Lelo indicated now that we'll be coming back soon to do a study on HIV positive people, looking at the stigma among HIV positive people in certain districts within the Northern Cape. It's not Northern Cape. In Northwest. It will also be a national study, but our hope is that this event and this dialogue is a start of a stronger relationship that can be formed with province and the HSRC. We would like to especially thank the Office of the Premier, and the Provincial Council of AIDS, because, I mean, our team worked very closely with the Office of the Premier and the Council to actually get the invites going, to actually have this event possible. So once again, we would like to thank you, and thank you for welcoming us to your province. Thank you very much.
Okay, as Mr. Mawelela is coming through, please scan the QR code here just to respond or evaluate the event. Obviously, as Dr. Jooste has mentioned, this is the first time that we're doing it. We need to look at how do we strengthen it when we come back, possibly with funding, to also do all the districts and everything else that was mentioned today. So just, it should not take you more than 5 minutes, just to reflect on how the event went and some of the lessons that can be learned. So as you do that, he would also be saying a few words. Thanks.
All right. Thank you very much, Program Director. Yeah, I think it was a very, very useful day today with the information that we have received from this session. I think for me, the question that was raised by Reverend Pastor Mwepi, it is a very important, question. But I think this study, for me, more so that it is done by one of the institutions of government, it's a very important study, because if we don't have information such as this one, we will travel a road that we don't know where it is taking us, and where we are getting to. So for me, I think it gives us a very important information, more so that we have limited resources, so that we can then make our minds and say, what are the best options, to pursue, to deal with the question of HIV and AIDS. I don't want to repeat what the findings are, but I think for me there were two areas that I think we need to pay attention to. The teenagers, the 15 to 19, as well as that cohort of 50 and above. I think that is where our efforts needs to be focused on, to ensure that they are virally suppressed. And I think it will contribute immensely to the reduction in the HIV AIDS cash. Anyway, I was called here to thank everybody who's here. Let me start by thanking our program directors for having done a sterling job. Let me thank all the presenters that have made their contribution to this meeting. Let me also thank all the implementing partners that are working with us in the province. I think we've had during the contribution by the various tables that they are doing some good work in the province. Let us also thank our development partners. I know they assist us a lot. I work closely with the Secretariat for the PCA. Most of the time they come and assist us with a lot of funding. Let me thank all the departments that are here for taking this HIV/AIDS program seriously. And then lastly, let me thank the Secretariat for having worked with the HSRC to coordinate this program. I think we have made it, we have exchanged the information, but I think this partnership doesn't stop here. We will continue to engage during lunch and even beyond lunch in our different platforms. Thank you very much, and I want to wish you safe travels as you go home. I'm not sure, Momokoti, where the lunch is being served, but I guess it will be at the restaurant, yeah. Thank you very much.